Good morning everyone. If I'm audible and visible, please send your thumbs up in chat box. Okay, so let's start. We are going to discuss clinical questions of surgery. So this is first session. So let's start. First question, a 35 years old US citizen, presented to OPD with abdominal pain and fever. He had history to visit to India 3 months back. Ultrasound was performed showing 5.5 into 3 into 4 centimeter cavity in the right lobe of liver. You can see here ultrasound finding is given below. So which of the following is appropriate treatment? Clear? So guys, first you tell me what is the diagnosis. What is the diagnosis in this case? Tell me. Waiting for your reply. First tell me Rishikesh Chaudhary, SVN Prasad, Dharni Narola, Arushi. Okay. So first tell me what is the diagnosis. This patient is having pain and fever and there is cavity in the liver. So obviously it's liver abscess. Guys, tell me which liver abscess? Benazir Hussain. Yes, amoebic liver abscess. Why amoebic liver abscess? Because patient is a US citizen but there is history of visit to India. Means history of visit to endemic countries. All of you know that amoebic liver abscess, it is caused by which organism? It is caused by Ent amoeba histolytica. So it is caused by Ent amoeba histolytica. Ent amoeba histolytica. Clear? You know that the route of infection is fecal-oral. Whenever patient is having amoebic liver abscess, in this case what is the treatment of choice? We give high dose oral metronidazole. So high dose oral metronidazole is given. But what is the problem? In some of the patients there is high risk of rupture, that is known as high risk abscess. So what is the definition of high risk abscess? Yes, high risk abscess means whenever patient is having left lobe abscess, if the patient is having left lobe abscess or size of abscess, it's more than 5 centimeter. Clear? So whenever ultrasound finding is given, you will notice that 3-dimensional finding will be there. Sometimes only size is mentioned, sometimes 3-dimensional finding. So here it is given 5.5 into 3 into 4 centimeter. So any single dimension more than 5 centimeter. Any single dimension more than 5 centimeter, that is indication for aspiration. So in this case what we are supposed to do, we have to go for aspiration. And how we can aspirate? We are going to insert the pigtail catheter. Clear? So obviously we are not giving oral paromomycin. We are not going for laparotomy and surgical drainage. We have to drain. So what is the best way? The best way for drainage, that is pigtail catheter insertion. Pigtail catheter insertion. Clear? So Pravati Babu, correct. Majority of you were correct, guys. Some of you were marking oral metronidazole. These kind of questions are asked frequently. So what you have to focus? First, make the diagnosis. Second, look for the complicating features, whether there is increased risk of rupture or not. Means what is the location? It is in left lobe or the size is more than 5 centimeter. So in this case, what is the correct answer? Correct answer is C. It will be helpful for FMG also, guys, so you can attend this session. Now another easy question, it was asked many times in exam, only there is variation in the language. Okay, so let's see who is going to reply correctly. Yes, 25 years old male brought to the emergency with multiple injuries due to road traffic accident. After 2 days in hospital, see this duration, 2 days in hospital, the patient developed dyspnea, altered sensorium and most characteristic feature, petechial rash in axilla and chest. What is the most probable diagnosis? Yes, everybody is correct. Sophia, Rishikesh, Azhar, Preeti, Benjir Hussain, Dr. Nisi, Dr. Narola, Rameshwar Nayak, Kapil Dev Chaudhary, Chirag Yadav, all of you are correct, guys. So what are the clues for fat embolism? For fat embolism, yes, the patient should be having history of multiple long bone fracture. So these patients are having what? Multiple long bone fracture. So patients are having multiple long bone fractures. Clear? So usually after road traffic accident, when multiple long bone fractures are there, second, Usually at the time of presentation, patient is not having altered sensorium. So in fat embolism, altered sensorium, breathlessness or dyspnea, these are prominent after 48 hours. So what happens after 48 hours, patient is going to develop breathlessness or dyspnea, and patient is going to develop altered sensorium, and all of you know the characteristic feature of fat embolism, characteristic feature that patient will be having what? Petechiae or petechial rash, and typical locations are axilla, chest wall, conjunctival fold, retina. Axilla, chest wall, conjunctival fold and retina. So majority of you are correct, guys. Majority of you are correct. Clear? So fat embolism is responsible. Okay? Right. Now question number 3. It's an integrated question, asked in radiology also, asked in surgery also. Now see, match the following barium GI studies and their corresponding conditions. Okay, tell me what is the correct answer. Guys, tell me what is the correct answer. Dr. Deepa, actually English, because lots of audience cannot understand Hindi. So that's why it's difficult. Okay, so I think you can understand English. So no problems, right? That's why we are conducting it in English. Okay. So tell me guys, what is the correct answer? First you tell me apple core sign or apple core appearance. It is seen in which condition? Apple core appearance. Yes. Divya Reddy, Bhavesh, Pasha, Marksman, Sophia, Dr. Medico, Nisi. Yes. You know that apple core appearance or apple core sign, it is seen in carcinoma esophagus and it is seen in carcinoma colon also. Second, Fleischner sign. Fleischner sign, it is also known as inverted umbrella sign, right? Tell me, inverted umbrella sign or Fleischner sign, it is seen in which condition? Guys, tell me. This was asked in NEET PG. Fleischner sign or inverted umbrella sign. Abhishek Mishra, very good. Tuberculosis, very good. Ajher, Tanuja, Sophia, it is tuberculosis. So Fleischner sign, it is seen in tuberculosis. Third, antral pad sign. Guys, antral pad sign, it is seen in which condition? Kapil Dev. Antral pad sign, Suresh Sharma. Tell me, antral pad sign. Easy question. Yes, antral pad sign, guys, you know, it is seen in carcinoma pancreas. Sophia, everybody is correct. Karan Chaudhary, Geeky Medico, Ria, it is seen in carcinoma pancreas. And all of you know that coiled spring sign, when one loop of intestine enters into another, it is seen in intussusception. Clear? So what is the correct answer? A, 2, B, 3, C, 4 and D, 1. A2, B3, C4, D1. So correct answer for this question, B. Correct answer, it's B. These are the radiological images which are asked frequently. Have a look. Okay guys, so you can see here, this is what? This is apple core appearance. In this image you can see, this is apple core appearance, right? Apple core appearance, it's non-specific. It is seen both. It is seen in carcinoma esophagus also, and you can see it is seen in carcinoma colon also. But there will be difference of investigation. Whenever this apple core appearance is seen, you can see here apple core appearance. If it is seen on barium swallow, it is seen in carcinoma esophagus. And if it is seen on barium enema, you can see here. So if it is seen on barium enema, it is seen in carcinoma colon. So apple core appearance, this is non-specific. Okay. Second, can you tell me what is the name of this sign? This one. Guys, tell me, see this image and tell me what is the name of this sign. If you see, the ileum is narrowed, terminal ileum is narrowed, and what? There is rigid cecum, thickened IC valve. Rigid cecum, thickened IC valve, narrowed ileum, this is known as Fleischner sign. So what is the name of this sign? This is known as Fleischner sign. Fleischner sign. It is also known as inverted umbrella sign, and this was asked in NEET PG. Clear? Fleischner sign or inverted umbrella sign, this is asked in NEET PG. Second question, if you see here, yes, Here the ileum is looking like a string. Can you see? Persistent narrowing of ileum on barium will follow through. And what is the name of this? Persistent narrowing of ileum on barium will follow through. Yes, this is known as, tell me guys, what is the name? All of you know this? What is the name? This is string sign of Cantor. Geeky medico, you are correct. This is string sign of Cantor. Clear? So you know that this string sign of Cantor, it is because of persistent narrowing, means because of stricture. And what is the cause of Sterling sign? Sterling sign, it is because of ulcer in terminal ileum. So ileum becomes hyper irritable, and that's why on barium will follow through, there is narrowed appearance. So any patient in whom there is ulcer in terminal ileum and any patient in whom there is stricture in the ileum, Sterling sign and string sign of Cantor is seen. Clear guys? So you tell me, Sterling sign and string sign of Cantor, these are non-specific. It is also seen in which condition? Guys tell me. Sterling sign and string sign of Cantor. Sterling sign and string sign of Cantor. Clear? This is non-specific. It is seen in both GI tuberculosis as well as Crohn's disease. So it is seen in both GI tuberculosis as well as Crohn's disease. Clear? Everybody is correct. Pradyuman, Sayantini, Rushikesh, Khushi, Sophia, Geeky Medico, all of you, Rameshwar Nayak, all of you are correct guys. Now see this one. Easy question, tell me what is the name of this sign. Let me see who is the genius over here. What is the name of this sign? On barium study. Debo Priya Bandopadhyay, Dharni Narola. Tell me, what is the name of this sign? Guys, you see, this is the stomach. Clear? This is the duodenum. Here is the mass. Here is the mass. This mass is causing indentation. First person to reply, Dr. Tanuja, Geeky Medico, then Rushikosh Chaudhary, Vikas Raj, Sophia, Dr. K. Marksman. All of you are correct guys. So what happens? Whenever there is a tumor, it is causing indentation over antrum. So carcinoma head of pancreas, the patients who are having carcinoma head of pancreas, you can see here, it is causing indentation. And this indentation, it is known as antral pad sign. This is indentation. It is known as antral pad sign. So antral pad sign, it is seen in carcinoma pancreas. Carcinoma pancreas. Question, which part? You have to remember carcinoma head of pancreas. So apart from antral pad sign, what are the other signs which are seen in CA head of pancreas? See, first there is widened, yeah, or widening of C loop. There is widening of C loop of duodenum. What else? These patients have antral pad sign. There is antral pad sign. There is double duct sign. Double duct sign, and most important, reverse 3 sign of Frostberg. What's the name? This is reverse 3 sign. Reverse 3 sign of Frostberg. Clear? What you have to remember, that all these signs are seen in carcinoma head of pancreas. Very good Ankit. Ria, carcinoma head of pancreas. Clear? Next. See, almost every year in each and every paper, these image based questions are asked. So here you can see, this is claw sign. Why? Because of intussusception, and one loop is entering into another. So here you can see, this is coiled spring sign. So claw sign and coiled spring sign, both of these are seen in which condition? Intussusception. Claw sign, coiled spring sign, both of these are seen in intussusception. Clear guys? Very good. Nisi, Tanuja, Ria, Preeti, Abhishek, Arushi, all of you are correct guys. All of you are correct. Okay, now see this question. Now let me see who is going to mark the correct answer. Okay, during surgical resection for rectal carcinoma. Age of patient 60 years old patient undergoes LAR, that is low anterior resection. LAR, low anterior resection. Surgeon aims to achieve clear margins around the tumor to minimize risk of local recurrence. Clear? So we perform circumferential dissection. Clear? What is the term used to describe desired clearance margin for this procedure? Let me see who is going to mark this question correctly. And I know that all of you know the answer correctly. Clear? Everybody is correct. Chirag Yadav, Nishant, Abhishek, Ajhar Shah, Gujjar Dev, Divya Reddy, all of you, Vikas, Manish, Deepak Sharma, all of you know the correct answer. Let me tell you guys about margins. You know that in GI malignancies, how much margin we take? 5 centimeter. Proximal as well as distal. So in GI malignancies, how much margin we take? We take 5 centimeter. In GI malignancies. Clear? Both proximal and distal. There are two exceptions. First exception, esophagus, and you tell me how much margin should be taken in esophagus. Guys, in esophagus, we take 10 centimeter margin, and distal rectum, how much margin? In distal rectum, we take 2 centimeter margin. These are the exceptions. Clear? So proximally, if malignancy is there in the rectum, proximally we take 5 centimeter margin. Distally we take 2 centimeter margin. And how much should be the circumferential radial margin? Circumferential radial margin should be more than 1 mm. Circumferential radial margin should be more than 1 mm. So comfortable margin, radial margin, it's 2 millimeter. So circumferential radial margin, the comfortable radial margin, that should be 2 millimeter. Clear guys? So how much is the proximal margin here? 5 centimeter. Distal margin, correct, 2 centimeter. Radial margin, it should be more than 1 mm. So what is the correct answer? 2 mm. Clear? Proximal margin we discussed, that is 5. So this is the characteristic feature you have to remember. Clear? Clear guys? So this is carcinoma rectum, in which we are performing low anterior resection. So what are the important points related to margin? We discussed proximal 5 centimeter, distal 2 centimeter, circumferential radial margin should be more than 1 mm. So how much margin we take? 2 mm. Clear? It's a new fact you have to remember. Next question, very easy question. Just by looking at the image you can make the diagnosis. Only by looking at the image. So guys, you can see here. You can see that what kind of appearance is there. Clear? And now read the question. 35 years old female. See the age. Age is 35. Presents with tender swelling in her neck. On examination, palpable mass is identified where? In anterior neck region. So in anterior neck region, palpable mass, difficulty of swallowing and occasional hoarseness. Dysphagia is there, it means there might be involvement of which structure? Esophagus. Hoarseness means recurrent laryngeal nerve involvement. FNAC is performed. What kind of ultrasound guided? Histopathology reveals following image. Based on clinical presentation, histopathological finding, what is the most likely diagnosis? So what you can see here? You can see ideally the cell should look like this. Yes, this kind of pigmentation should be there inside. Clear? But what happens? You can see there is no pigmentation. So here optically clear nuclei is there. Can you see? This nuclei is optically clear and it is looking like orphan NEI. So this is known as orphan NEI nuclei or optically clear nuclei, and everybody is correct. Kushish, Soni, Nims, Yadav, Kumar, Sonu, Munish Kumar, Saurya Dutt, Majumdar, everybody is correct. So what is the correct answer guys? Correct answer is papillary. It is papillary carcinoma thyroid. Now one question for you guys. Tell me in which particular age papillary carcinoma thyroid is seen? Tell me. Tell me guys. Age group for papillary carcinoma thyroid. Simple question. Yes, you know that this papillary carcinoma, very good. Dr. Khurafati student is there. Deepak Sharma. Majority of you are correct. It is seen in third to fourth decade. Third to fourth decade means 30 to 40 years on an average. Okay. Follicular carcinoma, if you are talking about carcinoma. So, follicular carcinoma, this is seen in 6th decade, 60. What about medullary carcinoma? Again 6th decade. And most important, anaplastic. You know, anaplastic is seen in which decade? 7th to 8th decade. You know, there is another malignancy which is seen in 7th to 8th decade, around 70 to 80 years of age. Tell me the malignancy. Carcinoma prostate. So, carcinoma prostate as well as anaplastic carcinoma thyroid, these are seen in which particular age group? 70 to 80 years. Clear guys? 70 to 80 years. Second, very good, you know that FNAC cannot differentiate follicular adenoma from follicular carcinoma. Why? Because the diagnosis of follicular carcinoma is based on vascular invasion or capsular invasion. Clear? So, correct answer for this question is D. Easy question. This is diagnosed on the basis of the image. So, if you see this image first, see the image. What you can see here, you can notice that some kind of fusion is occurring here, right? And this is known as what? Hand joining sign. I am giving the clue. This is hand joining sign. So, this kind of, yes, fusion is there. This is hand joining sign. So, first you tell me what is the diagnosis. Guys, tell me what is the diagnosis. 5 years old child, recurrent UTI and abdominal pain. IVP is done in which there is hand joining sign. What is the false statement regarding this condition? Guys, tell me. Yes, Arushi Bhardwaj, Pradyuman, Riya, all of you are correct guys. This is a typical case of horseshoe kidney. So, what is this? This is horseshoe kidney. Horseshoe kidney. Clear? First, let me discuss horseshoe kidney. What happens? Then we will discuss the question. This is the horseshoe kidney in which kidney is fused at the lower pole. You can see here, it is fused at the lower pole. Which artery is going to prevent the ascent of kidney? You can see here, this is inferior mesenteric artery. What is the level of inferior mesenteric artery? All of you know, it is L2. That's why, what is the level of isthmus? Isthmus is L3, L4. Isthmus is L3, L4. There is high insertion of ureter with anterior transposition. And you can see in this case, there is medial calyx also. So, since there is medial calyx, if you perform what? IVP, what? This sign is known as hand joining sign because of medial calyx. Since there is high insertion of ureter with anterior transposition. So, high insertion of ureter with anterior transposition, and that's why what happens? There is flower vase like curve of ureter. What kind of curve? Flower vase like curve of ureter. Two characteristic signs on IVP. Clear? So, one, these patients are having hand joining sign and flower vase like curve of ureter. Now, see the associations. Horseshoe kidney, it is associated with Turner syndrome. This is associated with Turner syndrome and there is low risk of RCC. RCC can develop in horseshoe kidney. Clear? Now, see the options. So, it's a case of horseshoe kidney. Guys, it is associated with Turner syndrome. Correct or incorrect? This is correct. Associated with risk of renal cell carcinoma. Yes, there is low risk. This is correct. Horseshoe kidney lies above, can you see? Above inferior mesenteric artery. Tell me guys, it is located above or below? Below. Because inferior mesenteric artery is going to prevent the ascent of kidney. So, it is located below inferior mesenteric artery. Means this option is incorrect. It is located below. And what is the level of isthmus? L3, L4. So, level of isthmus, that is L3, L4. So, what is the correct answer? Option C is wrong. So, option C is correct. Tushar Patel, Riya, Tanuja, Marksman, Durgesh, Asad Baloch, Divya Reddy, Riya, all of you are correct. All of you. So, correct answer for this question C. Now guys, simple question, easy question. On the basis of question or image, you can solve the, on the basis of language or image, you can mark the correct answer. See this. This is the image. Okay. Now what you can see in this image, this is the localized ileus in which there is involvement of jejunum. This is which loop? This is jejunum. Now read the question. 40 years old male presents to emergency department with severe abdominal pain and tenderness. Clear? He reports that pain starts in upper abdomen and now radiated to back. Starts in upper abdomen, radiates to back. Also notices that pain is partially relieved when he leans forward or curls up in a fetal position. So on flexion, on leaning or bending forward, pain is relieved, partially relieved. Which specific sign is seen on abdominal radiograph shown below? So tell me guys, what's the name of this sign? I already gave you so many hints. Lovely Poison, Divya Reddy, Vikas, Dharni Narola, Tanuja, Dibopriya, Bhavika Sarode, all of you are correct. Guys, all of you are correct. This is which sign? This is what? Sentinel loop. What is the name of this sign? This is sentinel loop sign. Clear? So this is what? Localized ileus in acute pancreatitis. In patients of acute pancreatitis, localized ileus, that is known as sentinel loop sign. Tell me, what is regular sign? Guys, tell me, what is regular sign? Whenever patient is having pneumoperitoneum, so because there is presence of gas in the peritoneum and both sides of bowel is visible, that is what? That is regular sign. Tell me, what is Cullen sign? Cullen sign. So see the images. See first. In acute pancreatitis patient, this is supine film, this is prone film. In the supine film, you can see presence of sentinel loop. This is what? This is jejunum. This loop is jejunum. So this is known as sentinel loop sign. Okay. See this one. What is the name of this sign? Again, it is localized ileus in which what part of colon is visible? Only you can see transverse colon, but beyond this splenic flexure it is not visible. So what is the name of this sign? Very good guys. What is the name of this sign? This is colon cutoff sign. Again, it is seen in acute pancreatitis. Yes, Bhavika, very good. It is colon cutoff sign, right? Another question, again in the patients of acute pancreatitis, especially when there is hemorrhagic pancreatitis, because of retroperitoneal hemorrhage, there is bleeding along the facial planes. So when there is bleeding along the facial planes, you can see that there is ecchymosis. Ecchymosis around umbilicus, this is known as Cullen sign. And whenever there is ecchymosis around flank, ecchymosis around flank, this is known as Gray Turner sign. So you tell me, if there is ecchymosis around inguinal region, what is the name of that sign? Tell me guys. Yes, ecchymosis around flank, around inguinal region. What is the name of that sign? Tell me. Kushoni, Ria. Yes, first person to reply, Rahul Soni. Rahul Soni. Very good, Rahul. It is Fox sign. So if it is around inguinal region, this is known as what? Fox sign. Okay, Fox sign. Now you know what is regular sign. Here you can see in this patient of pneumoperitoneum, both sides of bowel is visible. Why? So both sides of bowel is visible because there is presence of pneumoperitoneum. This is known as regular sign. So what is the name of this sign? This is regulars. Regular sign. When both sides of bowel is visible. Clear? Because there is presence of intra as well as extraluminal air. Usually it is seen when there is huge amount of free air. So how you are going to confirm the diagnosis? We can go for upright view and we can make the diagnosis. Clear guys? So that is regular sign. Clear? Now tell me, this is easiest question, easiest. Tell me what is the correct answer. Okay, so 50 years old patient with history of progressive dysphagia. for both solids and liquids. For both solids and liquids. Regurgitation of undigested food and chest pain. Barium swallow image is given below. Based on clinical scenario, what is the treatment of choice? Tell me. First, what is the diagnosis? What is the diagnosis? Tell me guys, what is the diagnosis? Yes, Riya, Rahul, Marks, Kush, Manish, everybody is correct. You know that this patient is having dysphagia for both solids and liquids. Let me give you a hint. Anywhere, if you are going to find a question in which dysphagia is equal to liquids or solids, or dysphagia is more to liquids, it's a hint. It's a hint for achalasia cardia. It's a hint for achalasia cardia. All of you know that what's the problem in achalasia cardia? Yes, there is absence of LES relaxation. So LES is not relaxing. So there is dysphagia more to liquids as compared to solids. And if you see this image, what is the name of this appearance? This is bird beak. Name of this appearance. On barium swallow you can see bird beak, pencil tip, rat tail appearance. All these findings are suggestive of what? Achalasia cardia. So apart from dysphagia, what else patient is having? Regurgitation. This patient is having increased risk of aspiration. So for achalasia cardia guys, what is the treatment of choice? You know, we are going to perform Heller's cardiomyotomy. And what is the treatment of choice? It is laparoscopic Heller's cardiomyotomy. So PPI, it is given for which condition? If patient is having peptic ulcer, patient is having GERD, for symptomatic relief. Endoscopic dilatation we can do, but effect is not long lasting. H2 receptor antagonist not used. What is the correct answer? Treatment of choice, it's laparoscopic. This is laparoscopic Heller's cardiomyotomy. So this is laparoscopic Heller's cardiomyotomy. Clear? So what is the correct answer guys? Correct answer is C. C. See here, what is the bird beak sign? So you can see this kind of appearance. The same appearance is also known as rat tail or pencil tip appearance. So bird beak sign, rat tail appearance and pencil tip appearance, all these are seen in achalasia cardia. Next question. Similar questions were asked previously many times. Tell me what is the correct answer. Yes, 40 years old female presents with fatigue, bone pain, recurrent kidney stone. So what? Fatigue overtones, bone pain, painful bones, kidney stones. Yes, kidney stones, abdominal groans, psychic moans, fatigue overtones. You got the point? Laboratory investigation revealed elevated serum calcium and low serum phosphate. Based on the clinical scenario, which of the following is best investigation to arrive at a diagnosis? Guys, first tell me what is the correct answer here. What is the diagnosis here? All of you know what is the diagnosis. This is primary hyperparathyroidism. Primary hyperparathyroidism. Clear? And you know that primary hyperparathyroidism, it is characterized by, yes, kidney stones, painful groans, painful bones, abdominal groans, psychic moans, fatigue overtones. Clear? What is the most common cause? Parathyroid adenoma, and it is solitary adenoma, usually located in inferior parathyroid. Most adequate or accurate and most commonly used investigation, it is cystamebi scan. So this is most accurate as well as most commonly used for parathyroid adenoma. And you know here the most common cause is parathyroid adenoma. Clear guys? So this is parathyroid adenoma. What is the correct answer for this question? Correct answer is B. So you can see here, whenever we are performing technetium 99 cystamebi scan, immediately you can visualize what? Thyroid gland. You can see submandibular and parotid gland. But after 3 hours delay, you are going to find out, yes, the uptake in parathyroid adenoma, so you can localize it. So you can easily localize that this is the adenoma, and it helps in surgical removal because it is going to localize. Clear? So it's a cystamebic scan. Next, very easy question. Let me see who is going to mark this question correctly. 45 years old male with severe flank pain, hematuria. Imaging studies reveal presence of Staghorn calculus more than 4 cm, filling significant proportion of renal pelvis and extending into calyces. Based on the clinical scenario, what is the treatment of choice for the patient's renal calculus? Guys, tell me, what is the correct answer? What is the treatment of choice for this renal calculus? Simple. So tell me, what is the treatment of choice? Yes, this is Staghorn calculi. Debopriya, Dharni Narola, Divya Reddy, Lovely Poison, GRS, Bhavika, Sophia, Khushi, all of you are correct. Usually for Staghorn calculi is very large. It causes silent destruction. So a single technique is usually not sufficient. What we do? We use sandwich technique. So usually we go for PCNL plus ESWL. We go for PCNL plus ESWL. But sometimes in the exam, only one option is given. And if a single option is given, what you have to choose? You have to choose PCNL. Percutaneous nephrolithotomy. For Staghorn calculi, we are going for PCNL. So in which kidney stones we are going for PCNL? What are the indications of PCNL? Very important. First, guys, tell me, size of stone? More than 2 cm. If there is distal obstruction, patient is having distal obstruction. If there is lower calyceal stone, if patient is having UTI, if patient is having hard stones and Staghorn calculi. Clear, guys? Now tell me, what are the hard stones not easily broken by ESWL? Simplest question. Hard stones not easily broken by ESWL, mnemonic is BHC2. So full form, this is bruchite, this is hydroxyapatite. So this is bruchite, hydroxyapatite, cysteine and calcium oxalate monohydrate. Clear, guys? So simple question for all of you. Tell me, out of these stones, 4 stones, which one is hardest? Let me see. Yes, which one is hardest? Hardest stone. Arushi, Bhavika, hardest stone. Yes, it is cysteine. Cysteine stone, it is hardest. You have to remember, it's a question, cysteine stone, that is hardest. Clear? Clear, guys? Now see the next question, very easy. Yes, tell me what is the correct answer. 10 years old female presents with history of recurrent UTI, continuous dribbling of urine. Okay, patient has never achieved continence since birth. On physical examination, no palpable bladder. Based on clinical scenario, what is the most likely diagnosis? Tell me, guys, what is the most likely diagnosis? Yes, Satish Majumdar, Abhishek Mishra, Suprit Singh Khurana, Debopriya Bandopadhyay, all of you are correct. What is this condition? Manish, Khushi, Lucky Poison, Riya, Sandeep Chaudhary, Lovely Poison, Somajit Mandal, all of you are correct, guys. What is the correct answer? It is ectopic ureter. In VUR, recurrent infection is there, but incontinence is not there. In urethral diverticulum, there will be obstruction. In neurogenic bladder, what's the problem? Urine comes drop by drop. But this is not the congenital condition. Clear? Here, correct answer is ectopic ureter. In neurogenic bladder, bladder is distended, and after full distension urine comes drop by drop. What is the clue? No palpable bladder. Okay, so let me explain what happens here. See this picture. Okay, in this picture you can see that the patient is having two ureters. Can you see here? This is upper pole ureter which is opening in urethra, and this blue colored lower pole ureter which is entering into bladder. Okay, if you see the upper pole ureter, it is not opening into bladder, it is opening into urethra. So whenever there is abnormal location, of ureter, this is known as ectopic ureteric orifice. This is ectopic ureteric orifice. Now what's the difference? If you see the males, in males, ectopic ureteric orifice, it is going to open into prostatic urethra. What happens in females? You can see it's a female patient. In female patient, this ectopic ureteric orifice, it is going to open into anterior urethra. All of you know that there is external urinary sphincter. So in males, it is proximal to sphincter, and in females, it is distal to sphincter. So if it is distal to sphincter, what happens? You can see this is the kidney and this is the upper pole ureter. So whatever the urine which is formed by this upper pole ureter, it is going into urethra and it is coming out. So this patient will give you the history of continuous dribbling of urine or continuous incontinence. And second important point, what? Because of this lower pole ureter, since urine is going into the bladder, patient will be having normal voiding pattern. So classical finding, there is continuous incontinence. Continuous incontinence, there is dribbling of urine with normal voiding pattern, and it is seen in ectopic ureteric orifice. So what is the correct answer here? It is seen in ectopic ureteric orifice. So what you have to remember, in ectopic ureter, what is the most common site? So we discussed in males, posterior urethra, which one? Prostatic urethra. And what about in females? In females, it is anterior urethra. Anterior urethra. So you know that it is opening distal to sphincter in females. That's why these patients are having continuous incontinence characterized by dribbling of urine. Clear? Clear? So next question. Easiest question. Tell me guys, what is the correct answer here? 3 years old male child diagnosed with undescended testicle. Testicle is not palpable within scrotum. Imaging studies confirms that it is present in inguinal canal. Based on the clinical scenario, what is the ideal age range for performing orchidopexy? The surgical procedure, what is orchidopexy? Surgical procedure of bringing undescended testis into scrotum. Tell me. First question, tell me, what is the correct answer here? Yes, Abhishek, Nims, Lovely, Poison, Subhash, Riya, Anamika, Lucky, Kala, Gulzar, Lovely, Poison, Rahul, everybody is correct. So guys, one question for all of you. Tell me, what is the best age for orchidopexy in undescended testis? Best age for orchidopexy. Tell me. Best age for orchidopexy? Yes. All of you know, it is 6 months. This is 6 months. And you know, it should not be delayed. It should not be delayed by 12 months. Best age 6 months. It should not be delayed 12 months. So range is 6 to 12. If you have to choose best, you have to choose 6. 6. Everybody is correct. It's the 6 months. Okay. Easy question. Nowadays it is frequently asked. 60 years old female. Yes. Presents with dysphagia and weight loss. Upper GI endoscopy revealed tumor where? At GE junction, extending up to 1 centimeter below it. So what's the problem? This patient is having GE junction tumor where? It is extending 1 centimeter below GE junction. 1 centimeter below G junction. Clear? According to Sievert classification system, what is the stage of carcinoma, or what is this type? It is type 1, type 2, type 3. Which one? Let me see who is going to mark the correct answer. Sandeep Chaudhary. Sandeep Chaudhary, very good. Only one person is correct. Only one person, Sandeep Chaudhary. Soumyajit Mandal, 2 people. Soumyajit Mandal, only 2 people are correct. Third, Rahul. Rahul. Okay, guys, only 3 people are correct. Sophia. Now let me discuss what is Sievert classification. You know, nowadays, what is the most common site of carcinoma stomach? The most common site of carcinoma stomach is still antrum. It is antrum. Clear? But the malignancies are moving towards GE junction. If you remember, in carcinoma esophagus, there is increase in incidence of adenocarcinoma. Means in esophagus, the malignancy is going towards GE junction. And in carcinoma stomach, it is going towards GE junction. Clear? So, Sievert classification, it is for GE junction tumor. Now see, this is GE junction. Clear? So, whenever this is GE junction, so whenever tumor is located 1 centimeter to 5 centimeter above GE junction, type 1, located 1 to 5 centimeter above, it is type 1. Next, what is type 2? It is located 1 centimeter above to 2 centimeter below. So, 1 centimeter above GE junction to 2 centimeter below, this is type 2. And whenever malignancy is located between 2 to 5 centimeter below GE junction, this is type 3. This is type 3. So, here what is the correct answer? It is type 2. You have to remember Sievert classification, it is expected in the exam. Clear? So, what is the correct answer? Correct answer for this question is type 2, B. Another question related to hydatid cyst, have a look. 45 years old female, patient presents with abdominal pain and there is palpable mass in right upper quadrant. Imaging studies reveal a large cystic lesion with daughter cyst. This is the characteristic feature here. Large cystic lesion with daughter cyst. There is daughter cyst visible on ultrasound. Based on the clinical scenario, what is the most likely class of hydatid cyst? Guys, there are 2 sonographic classifications for hydatid cyst. One is Gharbee's classification and one is WHO classification. Whenever C is mentioned, this is WHO classification. CE, this is WHO classification. So, let me see who is going to mark the correct answer. Debo Priya, very good. Sophia, Subhash, Pallav Upadhyay, VK, okay, Pandit Akshay Sharma. Clear? So, majority is not correct. Okay. So, let us discuss the sonographic signs. First, what is Gharbee classification? Gharbee classification is going to divide cyst into 5 types, 1, 2, 3, 4, 5. Okay. Now, what is type 1? According to Gharbee classification, what is type 1? There is simple fluid collection in which there is unilocular unechoic cystic lesion with double line sign. So, simple fluid collection. What will happen in type 2? There is detached membrane. So, when detached membrane is there, it is known as water lily sign. After that, type 3. In type 3, there is cyst with daughter cyst in solid matrix. So, there is honeycomb appearance. In type 4, what will happen? So, type 3, there is honeycomb cyst, multiseptated rosette-like honeycomb. Type 4, there is complex cyst. So, complex heterogeneous mass. So, whenever cyst with heterogeneous hypoechoic and hyperechoic content. And what is type 5? It is calcified cyst. So, this is Gharbee's classification. Now, see WHO classification. So, what is CE1? Same, unilocular unechoic cystic lesion. Here you can see unilocular fluid collection. After that, type 2, CE2. In that case, you can see multiseptated rosette-like appearance. CE3, which is also known as type 3, which is further divided into C3A, C3B. whenever there is cyst with detached membrane only, if there is cyst with detached membrane only, that is water lily sign, that is C3A. And whenever there is cyst with daughter cyst, so presence of daughter cyst, it is suggestive of 3B. So CE3B, whenever there is daughter cyst, what is CE4? Just like type 4 of Gharbee's classification, that is complex heterogeneous mass. So you can see here hypoechoic as well as hyperechoic areas, and obviously 5 in which you can see calcified cyst. Clear guys? Calcified cyst. Clear? So see the question. See here. So you can see what is the most likely class, C3B, because there is presence of daughter cyst. Presence of daughter cyst. Clear? So correct answer for this question is C. You have to remember both classification, WHO as well as Gharbee's classification. Now this question, let me see, this is integrated question of pathology and surgery. You should be having adequate knowledge of both. So let me see who is going to mark the correct answer. 60 years old male presents with liver metastasis from unknown primary tumor. From unknown primary tumor. Immunohistochemical staining of liver biopsy specimen revealed negative staining for cytokeratin 7. So first important point, cytokeratin 7, it is negative. Positive for CK20, cytokeratin 20, it is positive. Negative staining for CDX1, CDX1 negative. Based on the clinical scenario and immunohistochemical markers, most likely primary site of origin for this metastatic adenocarcinoma. Okay guys? So first question, on the basis of common sense, tell me most common primary for metastasis to liver. Most common primary for metastasis to liver. Yes, carcinoma colorectum, colorectal cancer. So Adnan Kabir, Vikas Raj, only 2 people. Adnan Kabir, Vikas Raj, only 2 people are correct. Clear? So let me see how many of you are going to mark the correct answer. Riya, Prakhar Keshari. Okay. So guys, let's discuss. Whenever there is metastatic adenocarcinoma from lung, it is cytokeratin 7 positive. Clear? If it is from pancreas, it is also cytokeratin 7 positive. Clear? Cytokeratin 7 positive. Stomach is cytokeratin 20 positive, and colorectum, this is cytokeratin 20 positive, this is cytokeratin 7 negative. Now how to differentiate between stomach and colorectum? Yes, only colorectal cancer, these are negative for CDX1 and CDX2. CDX1 and CDX2 gene are tumor suppressor genes. Clear? So what happens whenever there is loss or decreased CDX1, CDX2, it is going to increase the risk of colorectal cancer. So this is important. You should be knowing the markers. So see the markers. Cytokeratins. These are intermediate filaments proteins, and these are present in epithelial cells. So it is present for which malignancies? Carcinoma. Okay. Sometimes the normal organs are going to express, and even tumors are also going to express. So now see cytokeratin 7. It is positive in lung, breast, endometrium, ovary, cervix, salivary gland, thyroid, cholangiocarcinoma, and in the option pancreas was there. So cytokeratin 7, it is positive in carcinoma lung, carcinoma pancreas, if it has metastatic adenocarcinoma. Cytokeratin 20 we discussed, it is positive in all colorectal adenocarcinomas and majority of gastric and pancreatic adenocarcinoma. Now, which one is negative for cytokeratin 7 and 20? Clear? So cytokeratin 7 and 20 both are negative in prostate, kidney, adrenocortical carcinoma, especially means urological malignancies, sarcoma, carcinoid, HCC and thymoma, both are negative. So this is related to cytokeratin. Now see CDX. So CDX1, CDX2, these are tumor suppressors. It means for tumor formation, their concentration should be decreased or these should be lost. Clear? So CDX expression, it is decreased or lost in many colorectal cancer. And whenever there is concomitant loss of both CDX1 and CDX2, yes, it is having strong impact of tumor formation in large intestine. Especially which part of large intestine? Especially the distal part. It means not only colon, in which malignancies there is decreased expression or these are negative in colorectal cancer. Clear guys? Clear? So if you read the question again, you found that lung, it is positive for CD, positive for cytokeratin 7. Pancreas, it is positive for both cytokeratin 7 as well as 20. Colorectum, positive for cytokeratin 20, negative for cytokeratin 7. Stomach, it is positive for CK20, but CDX1, CDX2 expression, it is low or it's absent only in colorectal cancer. So correct answer for this question, it's B. It's B. Okay guys. Now question number 16. Let me see who is going to mark this question correctly. Guys, tell me what is the correct answer here. 62 years old male, history of chronic hepatitis C and cirrhosis, presents with large HCC involving which lobe? Left lobe of liver. After thorough evaluation, multidisciplinary team decides the surgical resection is appropriate treatment. So we are planning for surgical resection. Surgeon plans to perform left hemihepatectomy. Surgeon wants to remove left lobe to remove the tumor, ensuring adequate oncological clearance. Considering planned left hemihepatectomy, which specific hepatic segment should be removed? Tell me, which specific hepatic segment should be removed in the patient? Tell me guys. Yes, let me see first person to reply. First person to reply, Deepak Sharma, Palwa Upadhyay, Chandni Keshwani, Tanuja, Soumyajit Mandal, Nisi, Bhavesh Soni, Nims Yadav, Soumyajit Mandal, Sai Nursing. Very good. Majority of you are correct. So guys, here the tumor is in left lobe. So what you have to perform? You have to remove the left lobe of liver. So obviously we are going to perform left hemihepatectomy. So you should know what are the segments located. See, in the left lobe of liver, in this image you can see what are the segments located. 2, 3, 4A, 4B. In right lobe, what are the segments located? 5, 6, 7 and 8. You know, segment 1, it is considered a separate lobe. What is the name? Caudate lobe. Segment 1, considered a separate lobe, caudate lobe. So if malignancy is located in left lobe, we are going for left hemihepatectomy. So what are the segments removed? 2, 3, 4. If we are going for right hemihepatectomy, what are the segments removed? 5, 6, 7, 8. All of you know that right anterior sector contains which segment? 5 and 8. Right posterior sector contains which segment? 6 and 7. Left anterior sector contains 3 and 4 and left posterior sector contains 2. So a simple question, if I am planning to perform extended hepatectomy, what kind of extended hepatectomy? I am performing extended right hepatectomy. So apart from removal of 5, 6, 7, 8, what are the other segments which are removed? Guys, tell me. In extended right hepatectomy, apart from 5, 6, 7, 8, what are the other segments removed? Yes, 4A, 4B. And if I am performing extended left hepatectomy, apart from 2, 3, 4, what else is removed? 5 and 8. Clear? So what is the correct answer here? I am removing segment 2, segment 3, segment 4A, segment 4B. So, segment 2, 3, 4A, 4B, these are the segments which are removed. Simple. This question, easy question, tell me what is the correct answer. 55 years old male presents with recurrent episodes of abdominal pain, diarrhea, weight loss. Pain, diarrhea, weight loss. Histopathological examination of biopsy shows transmural inflammation with non-caseating granulomas. Patient also has history of joint pain, uveitis. Based on the clinical scenario, what is the most likely diagnosis? Simple question. First clue, it's transmural. Second clue, there is non-caseating granuloma. Non-caseating granuloma. Another clue, that patient is having extra-intestinal manifestation in the form of joint pain and uveitis. So, it is focused to these two only, Crohn's disease and ulcerative colitis. Why? Because diverticulitis and ischemic colitis, it is not associated with extraintestinal manifestation. How to differentiate? All of you know that in Crohn's disease, it is transmural. And you know, ulcerative colitis, it is only involving mucosa and submucosa. In Crohn's disease, there is non-caseating granuloma. So, correct answer for this question, there is non-caseating granuloma. So, correct answer for this question is A. Okay guys, A. This is very, very important question, integrated between surgery and anatomy. Let me see who is going to mark the correct answer. Very, very important. Tell me, 65 years old male presents with 6 months history of rectal bleeding, changes in bowel habits, unintentional weight loss. A digital rectal examination reveals palpable mass. Where is the mass? In the rectum. Colonoscopy confirms presence of circumferential ulcerated lesion in mid-rectum. Based on the clinical scenario of patient undergoing surgery, which specific facial layer should be dissected to separate rectum from coccyx? Let me see who is going to mark the correct answer. Which specific facial layer? Only one person, Shreya Sinha, Khurafati student. Only 2 students marked the correct answer. Till now, only 2 students. Dr. Thansir Kabir. Dr. Thansir Kabir, yes, he is also correct. Only 3 people marked the correct answer till now. Pranav Kale, Riya, okay, Manish, right. So, guys, it's very, very easy actually. Now, what you have to do, there is a fascia between rectum and coccyx. Clear? So, suppose this is the rectum and this is the coccyx. So, there is a fascia here. So, obviously, this fascia is located anterior to sacrum. So, if it is located anterior to sacrum, what should be the name of this fascia? Presacral. This is very, very important. So, what are the names of fascia you have to remember? In relation to rectum, names of fascia. First, rectogenital. So, you can see here, see the smaller image. This is rectum and this is the genitalia. What? Prostate. In females, vagina. So, in between rectum and prostate in female's vagina, there is a fascia known as rectogenital fascia, other name Dinovillious fascia. So, you can see here this one, this is Dinovillious fascia. This fascia is located between rectum and genitalia, rectogenital, Dinovillious fascia. After that, you can see there is rectal fascia. So, 2 types. There is fascia propria, it is also known as visceral endopelvic fascia, and there is parietal endopelvic fascia. So, here you can see this green colored structure. So, this green colored structure here you can see here, this one. This is rectal fascia, which is also known as rectal proper fascia, also known as fascia propria. Since it is attached to rectum, it is known as visceral endopelvic fascia. Clear? And outside this presacral fascia just anterior to sacrum, you can see here, it is known as parietal endopelvic fascia. Clear? So, presacral fascia, it is also known as parietal endopelvic fascia. And there is rectosacral fascia. What is rectosacral? The fascia located between rectum and sacrum. So, you can see this one. This is rectosacral fascia, also known as Waldeyer's fascia. So, you have to remember the names. In exam, examiner is asking Denovillier's fascia. How to remember? This is rectogenital fascia. This is anterior to rectum. There is Waldeyer's fascia, other name rectosacral fascia, which this is located posterior to rectum. And there is a fascia which is located anterior to sacrum, presacral fascia. So, whenever we are performing total mesorectal excision for carcinoma rectum, you can see if we perform total mesorectal excision, you can see guys, I am going to excise what? Presacral fascia. So, which fascia? Between sacrum and rectum, presacral fascia. So, anterior to sacrum, this is presacral fascia which is excised. Clear? So, if you read the question, which specific facial layer should be dissected? It is presacral fascia. This is presacral fascia. Clear guys? Now, another easy question, see. A 45 years old woman undergoes mammogram as a part of routine breast cancer screening. The mammography reveals well-defined breast lump with circumscribed margins, no suspicious features. So, breast lump, circumscribed margin, no suspicious features. Radiology report assigns Byret's 3. Means Byret's 3 says it's probably benign. That's why short-term follow-up is recommended if it's Byret's 3. What is the next appropriate step in the management of this finding? Surgical excision? No. It's probably benign. Biopsy? Not recommended. Close observation without intervention? Close observation without intervention? No. Short-term follow-up? So what? Repeat mammogram in 6 months. So what is the correct answer here? We have to go for repeat mammogram in 6 months. So Byret's is very, very important. What is category 1? If you see category 1, there is incomplete assessment. And if incomplete assessment is there, additional imaging is required. Category 0, category 1, it's negative. And if it is negative, obviously you have to advise the patient to come for mammography next year. So routine mammography should be done. If it is category 2, that is benign, in case of benign also, what kind of advice is given? Come next year, means annual mammography is recommended. What was the question here? In the question, it was category 3. So what? It is probably benign. Here, short-term follow-up is recommended. Clear? So patient is going to repeat the mammogram and she has to visit the OPD. Category 4, suspicious. If it is 4A, there is low suspicion, 4B, moderate suspicion, 4C, there is high suspicion. Category 5, highly suggestive of malignancy, appropriate action is required. If category 4 is there, what? Biopsy is recommended because it's suspicious. Category 5, highly suggestive, that's why appropriate action is recommended. And category 6, it is biopsy proven malignancy. Nowadays, they ask you risk of malignancy. So how much is the risk of malignancy in category 1? 0. Category 2, 0. Category 3, more than 0 to 2%. In category 4, more than 2 to 95%. 4A, more than 2 to 10. 4B, more than 10 to 50. And 4C, more than 50 to 95. If it is category 5, more than 95%. So this is Byret's, frequently asked in exam. Now see guys, question number 20. Easy question. Let me see who is going to mark the correct answer for this question. Let me see. 60 years old male, painless swelling in the scrotum, gradually increased in size over past 5 months. On examination, swelling is trans-illuminated, no evidence of hernia, inguinal lymphadenopathy. On clinical scenario, most common cause of this condition. First, you tell me what is the diagnosis. There is increase in the size, slow increase over long period of time, clear? And trans-illumination test is positive. Simple question, what's the diagnosis? Guys, what's the diagnosis? Trans-illumination is positive, painless swelling in the scrotum. So obviously, what's the diagnosis? Bhavika, it's not varicocele. In varicocele, trans-illumination is not positive. In varicocele, trans-illumination is not positive. Let me give you the hint. This is the trans-illumination. Now tell me what is the diagnosis. This is the trans-illumination. What is the diagnosis? Tell me guys, easiest question. Trans-illumination is positive here. Hydrocele, very good. This is hydrocele. Got it? What is the most common cause of secondary hydrocele? And now mark the correct answer. Most common cause of secondary hydrocele. Secondary hydrocele. Mark the correct answer. Yes? Most common cause of secondary hydrocele. You can see the options. Epididymoarchitis. Very good. Sophia, Basavaraj, Dr. Nisi. All of you are correct guys. It is epididymoarchitis. So most common cause of secondary hydrocele, that is epididymoarchitis. This is the most common cause of secondary hydrocele. You can rule out the other options. Testicular trauma, it is not painless. Varicocele, there is bag of worm-like sensation. Trans-illumination is not positive. In idiopathic scrotal edema, yes, there is edema of the scrotum. So trans-illumination test is not positive. Clear? Clear guys? So correct answer is option A. So correct answer is option A. So this was the clinical question session guys. Yes, this was really very interactive. PrepLadder is introducing ProPlan. We already discussed India's only clinical QBank. It's the ultimate practice packed combo for next preparation. For 6 months, you can get this subscription only for 12,999. 12,999, and the link is provided in the chat box. Link is given in the description. So what you will be getting? First, QBank next edition test series. There will be treasures, there will be previous year questions. So why QBank next edition? It's must have for your next preparation. You must be knowing that next has been postponed, but what? Next is going to come because the draft is ready, every announcement has been done. So it might be postponed, but it will be there. So your preparation should be based on clinical question. Whatever videos you are watching is fine. Clear? So our preparation strategy, it's fine, but what? Application of knowledge, practice strategy should be different. So you should practice clinical question. So this QBank next edition, it's the India's only clinical QBank. You can leave everything else, but you should not leave it. These clinical QBank will strengthen your problem solving and analytical skills. Whenever we are solving clinical questions, what happens? Yes, it is going to improve the retention for longer duration. Apart from this, comprehensive explanation will be there, which will help you to learn art of ruling option, because whenever we are solving MCQs, you know, sometimes we are stuck between two options. So it will help you in ruling out the options, and there will be, what happens? There will be two types of questions. So you can easily jump between clinical and paraclinical questions, and there will be integration between clinical and paraclinical subjects. So each question comes with a learning objective, providing takeaway for a better understanding of topic, and quick revision is made easy. Why? Because there is a special section in which treasures are covered. Treasures are covered. So thank you guys for the interactive session. Beautiful audience. Best of luck for your exam. Keep working hard. Definitely you are going to crack the exam with flying colors. Good luck.